If your chronic pain levels vary throughout your menstrual cycle, change drastically during perimenopause and menopause, you've probably assumed and maybe have also been told that it was hormonal. And you've been told that as if that explains everything. Unfortunately, it doesn't. So in this series, we're going to break down exactly what is happening to your hormones and how that affects your nervous system and therefore your pain. Starting with estrogen, what most people don't understand is that estrogen can make pain better or worse, and it's dependent on the concentration. And that's because there's a biphasic curve to its pain modulation abilities. At higher concentrations, estrogen facilitates descending pain pathways in your spinal cord. It's that filter that keeps out insignificant pain signals from reaching your brain, only allowing the truly painful things through. At this higher concentration, we also get a release of natural pain-fighting chemicals called enkephalins, very similar to endorphins. But a lower concentration doesn't just mean that we've lowered that descending pain pathway, doesn't just mean that we lowered the enkephalins. There's actually a switch. So now lower concentrations of estrogen are actually more promoting pain instead of fighting it. A great example of how this works has to do with menstrual migraines. So from day 0 to 14 in your cycle, we see estrogen in purple here have this nice steady rise. And that gives us the nice protective effects of estrogen. But around day 14, when we'd like to see ovulation, there's a withdrawal. And it's a very sudden drop off in estrogen. And that's the flip from protecting you against pain to causing pain, because this sudden drop activates that trigeminal nerve system, which releases CGRP, the molecule behind most of the pain from your migraine. Now, progesterone works a little differently. When its levels are higher, it increases the calming neurotransmitter GABA. So with the sharp withdrawal of estrogen, we trigger a migraine, but a couple days, maybe a week later, when progesterone is higher, we have the protective effects of GABA. This can also explain why a lot of people's chronic pain improves during pregnancy, because progesterone remains higher throughout pregnancy. The biggest issue with all of this, though, is that hormones are not cut and dry. And what I haven't had explained in a conventional medical setting before is that your body is constantly metabolizing or converting hormones into different metabolites or forms. And it's those metabolites that are the most important piece of this story. And that's what we're going to break down in the next video. In the last video, we talked about how sex hormones such as estrogen and progesterone can either worsen your chronic pain or improve it. But I left off by saying it's not the hormones themselves, it's the metabolites that are doing all the work. Here's what I mean. Now, it's worth noting that this pathway starts with cholesterol. So if your cholesterol levels are naturally low, or your doctor just thinks lower is better and they've controlled them way too low, that's going to be an issue, because cholesterol turns into pregnenolone, which becomes progesterone. In the last video, I said progesterone increases GABA, which helps decrease pain, but that wasn't entirely true. See, progesterone gets metabolized in the liver into two different metabolites, beta and alpha. It's that alpha metabolite that turns into allopregnanolone, and that is what is increasing the levels of the calming neurotransmitter GABA. Now, pregnenolone can also get converted into DHEA, which gets converted to testosterone, converted to estrogen. And we were very clear about how more estrogen tends to help pain and less estrogen tends to cause pain. But estrogen's not the whole story. You have three different types, 1, 2, and 3. And E1 can get metabolized even further into 2-OH, 4-OH, or 16-OH metabolites. And this is where more is better isn't always true, because more of this 4-OH metabolite can actually start to push us more towards pain, whereas this 2-OH metabolite can actually be a little bit more protective against pain. But it's not the 2-OH that's doing the heavy hitting. This 2-OH metabolite has to be methylated by your genetics to 2-methoxy-E1, And this is what is really doing the heavy hitting when it comes to fighting chronic pain. So if that wasn't complicated enough, we need to make a few more things really clear. First, this methylation process is very heavily regulated by your COMT gene. And we actually talked about this a few videos ago because it's not uncommon to have a genetic mutation in this gene, which makes this process real sluggish. So you might have enough 2-OH, but you can't make enough of the good 2-methoxy-E1. All right. Now, say you have a blood test and your estrogen comes back low. So your doctor puts you on hormone replacement therapy to increase that estrogen. But what happens if your body has a predilection towards converting estrogen into the potentially more harmful 4-OH metabolite? More estrogen could actually worsen the problem instead of help it like we would expect. Now, the third thing is back up to pregnenolone because we said it creates progesterone, which eventually creates GABA. Pregnenolone eventually creates estrogen, which creates 2-methoxy-E1. But it's also used to make cortisol, your stress hormone. So if you are chronically stressed, now we see something called the pregnenolone steal. All of your pregnenolone goes to your adrenal glands to make cortisol instead of making progesterone and estrogen. So this is just going to ramp up your chronic pain even more instead of helping it. All of this comes down to the difference of your doctor is either treating your pain or they're treating you. Because if they're not giving you real treatments to lower cortisol levels, if they're not addressing your liver health and not looking at your genetics and methylation pathways, this is the difference between managing your chronic pain and actually ending it. Testosterone is naturally protective against chronic pain, and here's how. Your brain cannot be bothered with every piece of information trying to get up to it, especially insignificant pain stimuli. So it's created a filter to keep out the insignificant stuff and only allow in the truly important stuff like significant pain. This system is called the supraspinal pain modulatory circuitry, and it starts with a region called the periaqueductal gray, which we've talked about before. This region is jam-packed full of receptors for testosterone. So when testosterone binds to the periaqueductal gray, it activates the rostroventral media medulla. You don't need to know that, but that goes down to the spinal cord where we have a cross section. Information comes in through this dorsal horn, especially pain. Your descending pain pathways live in this dorsal horn. They put up a wall so that the insignificant pain stimuli cannot make its way through to the brain. But if testosterone is low, then this whole system falls, the wall breaks, and all the pain is allowed to get through to your brain, whether it's important or not. Now, there's a few reasons why you might not be making enough testosterone. Beyond the obvious that women just don't make as much as men, you should still be making enough to activate this system. So if you're not, and anybody for that matter, is not making enough testosterone, we have to think about a few things. One, as we become more sedentary with chronic pain, muscles start to atrophy, we make less testosterone. The second has to do with the last video in that sex hormone pathway, where we need cholesterol to make testosterone, estrogen, progesterone, etc. If your cholesterol is too low, you're not going to make enough testosterone. The three, there was that pregnenolone steal, remember. That's where pregnenolone ends up getting converted into the stress hormone cortisol, and there's not enough left over to get over to this side of the pathway to make testosterone. So if your doctor is not looking at the complete picture of your sex hormones, this system just might be the one that suffers the most. So you've been told that stress is contributing to your chronic pain, but you've probably never been told how. And that makes all the difference when it comes to treating it. All the information coming from other parts of your body up to your brain first have to travel through this dorsal root ganglion. Then they go into the dorsal horn of your spinal cord. This is where insignificant stimuli, especially pain, are supposed to get filtered out so that they don't ever reach your brain. Found in these two regions are a lot of glucocorticoid receptors. When your brain detects stress, whether physical, biochemical, or emotional, your brain tells the adrenal glands sitting on top of your kidney to release cortisol. This is your stress hormone. Cortisol then goes and binds to these glucocorticoid receptors, which help decrease inflammation and prevent more pain from reaching your brain. Unfortunately, these receptors are dose and time dependent. So in the acute phase, these receptors help you. But with more cortisol and for longer durations, something really interesting happens here. These receptors get phosphorylated and they shift from being anti-nociceptive, which is anti-pain, anti-inflammation, to pro-nociceptive, which is promoting pain and inflammation. Now, once this shift happens, we see a downstream activation of your immune system, and your immune system does what your immune system does best. It increases nuclear factor kappa beta, increases NLRP3 inflammasome. If you're paying attention, these are chronic inflammatory pathways that we've talked about in the past and how you can calm both of them individually. But when we increase chronic inflammation, we then sensitize our nociceptors, those pain receptors, even more. So now you start to feel more and more pain to less and less stimuli over time. Now, like I mentioned earlier, this isn't just about managing your emotional stress. Physical and biochemical stressors increase cortisol as well. Things like joint restrictions, chronically tight muscles, inflammatory diets, food sensitivities, a disrupted gut microbiome, they can all increase cortisol levels. So stress, just like chronic pain, needs to be treated from all angles, physically, biochemically, and emotionally.